Treatment of respiratory insufficiency, I'm going to skim over it because Sherry's going to go into it in a much more in-depth. Bi-level positive airway pressure, VPAPs, IVAPs, or trilogies, otherwise known as non-invasive positive pressure ventilation, otherwise NIPPV. There should be an I there. Airway clearance, treatment, nebulizers, cough assist, vital cough, and death. All of this you're going to see, you're going to have hands-on today. Changing to a different mask may be helpful for patients for improved desensitization, and comfort. Very often the patients say, oh, I just can't stand this mask. I just can't stand this interface, this nasal pill. There are 100 more out there. Just because that doesn't work doesn't mean that you have to stop there. Contact us. We'll get the best interface for them. It takes time to get desensitized. Raising the head of the bed, something as simple as that, will help with their respiratory difficulties, like gravity assist, bedside fan, medications to aid in relaxation, lorazepam or anxiolytics, and to relieve feelings of air hunger using Roxanol or liquid morphine. We do not usually start anybody on lorazepam or anxiolytics unless they're on a bypass in a trilogy or so on, because it can affect the respiratory drive, suppress the respiratory. Important reminders. The most important thing you're going to leave here today, oxygen is contraindicated for the person with ALS unless it's led through the NIPPV, unless it's led through the bypass. Why do we think that? Why is it oxygen contraindicated? This is not a disease of the lungs. This is a disease of the diaphragm. So the diaphragm is impaired. So these people retain CO2, the waste product of oxygen. So the CO2 narcosis, CO2 will throw them into CO2 narcosis. So no oxygen concentrator in these patients. ALS patients experience hypoventilation and accumulate carbon dioxide. They're more simple terms than I said. Using oxygen without a VPAP could result in the buildup of carbon dioxide and eventually respiratory failure. So you're not doing them any favors. Diaphragm pacer. This is one of the newer treatments for ALS. Controversial, not being used very much anymore. It was a clinical device trial at Northwestern and all over the country. So there are a few people still out there with this. It's a pacemaker for the diaphragm, essentially is what it is. So it improves respiratory function, surgically implanted via laparoscope. Electrodes will be sticking out. It's implanted in the abdominal area by laparoscope, and you will see these electrodes coming out attached to the pacer. And these people control it. It's like a patient-controlled analgesia. Usually they use it at night. This is the company that invented it, I should say, Dr. Anders out of Case Western in Cleveland. Fatigue. This is the major complaint of patients. Increased work of breathing for patients with respiratory insufficiency. Their breathing just exhausts them. Okay? ALS patients use more energy for normal functions such as breathing, eating, speaking, and any physical exertion. Energy conservation is a must. Balancing rest with activity, shower days, as I said, just for doing their ADL, can be exhausting. Keep in mind the progressiveness of this disease. Help needed with ADLs will change as the patient declines. So your plan of care, the first day you go in there might change 2 days later, 3 days later, constantly might change. Depending how aggressive the disease is and how rapid the progression is. Aches, pains, cramps, and spasms. Generalized discomfort may be relieved with repositioning, range of motion, and massage. A pill is not always because stretching passive range of motion can, you know, if someone says, oh, God, my leg is cramping, just don't say, oh, you need to take morphine, or you need to take codeine, or you need to take a Tylenol, or whatever. Stretch. That'll sometimes relieve their discomfort. Massage is fabulous with these patients. Analgesics, antispasmodics might work, such as baclofen, tizanidine, can relieve the muscle cramping. Maintaining good hydration, these patients get so dehydrated because swallowing becomes an issue. So dehydration can be what's causing the cramping. So just hydrating them. Lorazepam and Tensol drops for the laryngospasms. Gabapentin may relieve neuropathic pain described as numbness, burning, or sharp shooting pain. This is not visceral pain like a cancer patient. This is very different. Nothing could be worse, dysarthria. Nothing could be worse than not being able to call for help, communication, express their needs to their family and friends. Alternate methods of communication are readily available. So what we do, we try to tune everybody up before we refer them to hospice, because we know under Medicare they won't pay for a speech-generating device after they're in hospice. So we try to tune them up at the clinic, or all of us who see our patients at home, and get them on board with all of these pieces of equipment, because a speech-generating device with an eye gaze can be over $22,000. So we try to get all of that in place. If they come to you, they have, say, refused or declined. Refused is too strong. Declines having a speech-generating device. Oh, anybody can understand. No, we all can't understand. And they're writing. Well, they no longer can write. They can't use their iPhone anymore because they can't push the buttons. They can't use their iPad. They need a speech-generating device, and they come to you, and they don't have one. Call up. We have a loaner pool of equipment. Or nobody should go without being able to. Okay, so prior to entering hospice or nursing homes, alternate, we try to get them tuned up, as I said. Check for loaner devices with less turn. Simple tools such as letterboards. We start simply. We don't start with just a speech-generating device, because there are some people who are not computer savvy. So we start them with picture boards, flashcards, writing pads, magnadoodles, dry erase boards. Intermediate devices such as iPads using text-to-speech apps. Speech-generating devices that use eye gaze technology with a head mouse or a single switch. Lip reading and careful listening. Dysphagia. Muscles that coordinate the mechanics of chewing and swallowing may be impaired or non-functional. Ideally, the patient will be evaluated by a speech and language pathologist to determine if they are swallowing safely. There are at least 15 people on the team at the clinic. It's one-stop shopping. They come to see the neurologist, the pulmonologist, the ALS pulmonologist. We have two on we have 5, almost 6 now, neuromuscular disease neurologist specialists. We have neurology clinical nurse specialists. We have social workers. We have speech pathologists. We have genetic counselors, one of the only programs in the country that has genetic counseling. We have registered dietitians, so on and so on and so on. It's a very big team. People come, they come for 4 hours to their clinic. It's not drive-through. It's a very long, intensive. So the consistency of liquids and solids may need to be modified. Commercial thickeners like Thicket are available. Thickened juices, they can get them from the pharmacist. Pills may need to be crushed, taken with applesauce, yogurt, or similar pudding, or changed to a liquid formulation. Suggest high-calorie foods and nutritional supplements to stop or minimize weight loss. What will cause a more rapid progression with this disease is malnutrition, dehydration, and poor respiratory. So none of them are isolated. They all go together. So good respiratory care, good nutrition, good hydration will give these patients more quality and a long course. Okay, teach your patient safe swallow techniques to prevent risk of aspiration. That's the number one cause of pneumonia, is aspiration. Teach PEG or gastrostomy placed prior to hospice admission may be needed to supplement oral intake or be used as the sole nutrition for patients who are nothing by mouth. Okay, I'm a hospice nurse. I was in the first group that took the hospice board in 95. Feeding tubes are absolutely necessary for a patient with bulbar, especially bulbar presentation.